posture, aren't we? So we're still going to look at, and probably we're going to look at standing up. So we're going to look at someone standing up, and we're going to start from the top, or the waist, wherever you want. But we're going to go one way or the other, aren't we? So let's start at the top. So we're going to look at, for example, from the side. We're looking for their posture. We're looking for their head courage, their shoulder posture, shoulder elevation, medial, external rotation of their shoulders, how they stand. You're going to look down from this position, looking down at kind of muscle mass, looking at any deformities, any scars, anything that doesn't look right, and you're going to comment on that as you go. You're going to follow that down, and you're probably going to finish around the pelvis. So with the elbow, you're not going to go right down to the ground, so we're not going to know about foot posture while we do the elbow. You just don't have time to do that. Then we're going to come from behind, and here we're looking the same. So we're looking at where does the head sit, looking at the head carriage, whether that's central, rotated, one side, the other, whether one shoulder's elevated, depressed, whether they look symmetrical. As you follow it down, again, just drop your arms by your side. We're going to follow that down, and we're going to look at their arms. We're going to look at how she carries her arms. So is she in an antalgic posture? Is she holding her elbow in one position? Is the angle look different? So we're going to look at what's called the carrying angle. So the carrying angle is this angle. So it's this angle we're looking at here. And in the female, that generally is much greater an angle just because of the way the pelvis is set. Okay, so we're looking at that angle. Does it look the same? Any deformities? Is the elbow flexed, extended, held in a position that looks uncomfortable? And turn towards me. Third position, we're going to do exactly the same from this position. Of course, what we're looking at here is more, we're looking at the same kind of symmetry of head, shoulders, but now we're looking at the front of the arm where we're probably going to be able to see more bruising, more cuts, more whatever looks different from the front. Okay, discoloration, any reduction in muscle mass in the biceps, for example. When we've done that, we're going to screen the shoulder. And the way we're going to screen the shoulder is, and again, I don't mind, so on here it says flexion, abduction, and behind head, and behind back. So flexion, obviously, elbow, shoulder flexion, shoulder abduction, hand behind head, and hand behind back. Now, hand behind head and hand behind back are the reverse of each other. Yeah, so this is internal rotation and elevation, and this is extension and internal rotation. Yep. So all it's doing is combining movements, which means, and that's all we'd expect you to do, and we'd say, okay, stop there, don't go any further. Okay, so that's for the shoulder. The wrist, we're just looking at wrist flexion, extension. So we say, can you extend your wrist? Can you flex your wrist? And then you've screened the shoulder and the elbow. Then we're looking at range of motion. So we're now looking at flexion actively, extension actively, pronation actively, and supination actively. Okay, and we said, didn't we, that obviously when we go into passive stuff, you should always do both sides, but depending on the time, you know, we might say to you, okay, you've done that side. So we'll keep an eye on the clock, and we'll always make sure that you're ahead and not, you know, and for most people we just say, just move on, we've done that. So when we do this passively, we're looking at extension with a degree of overpressure, looking for pain or resistance at the end of range. Flexion, overpressure, and then pronation and supination. Yeah, again with a little bit of overpressure. So you can overpress that there. Are we happy with that so far? Yeah. Then we're going to do exactly the same, but this time with resistance. So don't let me move you. Don't let me move you. Don't let me move you. Perfect. So I'm pushing down there, and don't let me move you. Fabulous. And then I'm going to get here. So now what you do is to turn your hand this way for me. Go. Good. And I want you to turn it the other way. And I'm resisting that. So that's the resisted done. Okay. So if you come and sit here for me that way, so I can read this. And so if we're looking at palpation, we're looking at the lateral condyle. The olecranon is at the back. Okay. The olecranon is the lump here. And when you extend, that lump goes in a recess called the olecranon fossa. So as we palpate, you can't really palpate the olecranon fossa with the arm straight. You have to unlock the elbow to feel the olecranon, the bump, the funny bone, if you like, and then you can feel the fossa just above it in that gap where your triceps tendon is. So the arm needs to be relaxed. Then you go to the radial head. Now remember, the radial head is, the thumb is on the radial side. Okay, so just remember that. The thumb's on the radial side. So if you follow the radius back, the bone is here from the thumb, and the radial head is in this region here. Okay, and remember it spins the radial head. It's like a cap and it rotates, and it's much smaller. At this stage, the radius is like a cap, a long rod, but the ulna is bigger, and what happens is that changes. So as the ulna comes in, it gets much smaller and the radius gets much bigger, and they change their dimensions, and that allows for this rotation. So we're here on the radial head. We're going to palpate the ulna, which is this bone here, the the biceps tendon. Now the biceps tendon, you can get your finger on it. That's the biceps tendon there. So you can pull it out, you can stick your finger under it. When people tear it, you can't, you just kind of, you've got nothing to hook under. So
is that the one that you can do a hook test?
Yeah, it's called a hook test. We don't put it in, but yeah, you can do a hook test where basically, you know, you can hook under the tendon to see whether it's there. So that's the biceps tendon. The triceps clearly are the muscle behind, so the triceps tendon is here, and then obviously as we work up, we go into the kind of medial head of the triceps, the lateral head of the triceps, okay? And the triceps comes down like so. So the wrist flexor compartment, remember the wrist flexor compartment is on the inside. So all the muscles that flex your wrist come here, and all the muscles that extend the wrist go there, okay? So the flexor compartment sits here, and we can palpate down through the flexor compartment, and we know that the flexor compartment always comes off this area. Conversely, we know that the extensor compartment always comes off laterally. That's much more common to have a problem on the outside, on the lateral epicondylitis than the other. So we move on to special tests. Now, anything that valgus, your knee's going to go in. Okay, so think of anything valgus goes in, and anything varus goes out. So valgus, so I'm angulating it that way, and then varus this way. Happy so far? Yeah. So this kind of Coase's test, basically what we're doing is we are radially deviating. So we're doing that, which is really working the extensor compartment. So that's radial deviation. I'm going towards the radius, thumb side, radius. And then what I want to do is get them to kind of resist that for me. So extend your wrist. Good. And I'm kind of feeling in there as I extend the wrist. Does that make sense? With me so far? Yeah? Now, Mill's test is basically what you're doing is you're extending that and you're getting them to push away. Yeah? And what you're doing is working that compartment which pulls directly on there. Does that make sense?
Wait, so are you pushing?
Yeah, so
flexing?
Yep, so doing that and they're pushing away.
Okay.
Whereas the other one's more passive, this is more active.
Okay. And where do they feel pain?
Here, right on the condyle.
Okay.
Yeah, because you're pulling on the condyle.
And are you going down at all, or is it just?
So some of the tests say down, but I normally do it like that, and I get them to push away. Yeah, happy? Anybody want to do it differently? There's a slight flexion in there. To be fair, it doesn't make any difference.
Is that a test for like tennis elbow?
Yeah. Okay. So that's a test for lateral epicondylitis. Yeah, both of those tests are. Now, if you imagine I'm stressing this muscle and it's pulling on there, then conversely, the medial test is to extend that, and I would expect that to be on the inside. Does that make sense? You look confused? Yeah. No, generally. Are we happy?
Yeah.
Anything that involves this is going to stress. Anything to flexion on an extensor will stretch the extensor. Anything to the opposite way around. So as we come back into this position here, which is this test here, passive test, must be carried out in full extension. Okay, so basically we're doing that. Stressing that out. Now Jurgensen's test basically is a long head biceps test, okay? And what you're wanting this person to do is this. Okay, go. And I'm resisting, I'm looking for any pain or pathology down into here, any clicking, any pain in this biceps tendon here. And obviously it's reproduced again, isn't it, on the shoulder examination. Yeah? So, although they're not really doing it, you're getting them to do it. So what I want from you is I want this. Go. Good. And I'm just resisting. or actually, often it's just match me, don't let me do it. Okay, and you provide that force. Now, Tinel's test, on the inside here, your ulnar nerve passes through here into this gap, this space. And it's when you smack your elbow and you get pins and needles in your fingers, that is where you're smacking the ulnar nerve, basically. So what we're going to do is find that spot and tap it. So there's a bridge, there's a gap, a valley there. From there to there, and it's there. Just find it and you tap it. And what you expect is that someone will get reproduction of their pins and needles in their fingers. Yeah?
How long do we tap it for?
Just a couple of times, just say, right, this is
Because,
a nose
some videos
test,
say,
I'm
like,
tapping
30
over.
seconds, but
Yeah, you wouldn't do it for 30 seconds. You just go, this is where the ulnar nerve is, this is a Tinel's test, you tap it like that, does that give you any pins and needles, reproduce any of your things? 5 seconds, 10 seconds, you need to for 30 seconds. And that's that. Good. Yeah?
Awesome.